Welcome to PICU Doc on Call, a podcast dedicated to current and aspiring intensivists. My name is Pradeep Kamath, and I'm a pediatric critical care physician and an associate professor of pediatrics at Children's Healthcare of Atlanta Emory School of Medicine.
And my name is Rahul Damania, a current second-year pediatric critical care fellow. Our episode today is dedicated to PICU applications of lipid emulsion therapy.
We are delighted to be joined by Dr. Kazzi Ziad, Associate Professor, Emergency Medicine, Emory School of Medicine, Director of the International Toxicology Fellowship Program at Emory University, Assistant Medical Director of the Georgia Poison Center, Board Member of the American College of Medical Toxicology, and the current President of the Middle East and North Africa Clinical Toxicology Association. I will now turn it over to Rahul to start a patient case.
A 14-year-old girl is admitted to the pediatric intensive care unit after acute ingestion of the calcium channel blocker Amlodipine in a suicide attempt. After initial fluid resuscitation in the emergency department, the patient is transferred to the PICU for norepinephrine infusion and high-dose insulin therapy. She continues to have profound hypotension. Lipid emulsion therapy is considered in this patient given her ingestion of amlodipine. Dr. Kazzi, we are so excited that you are here today to give us a little bit more background on how lipids can be applicable in the pediatric intensive care unit. How did lipid emulsion therapy begin? Do you mind giving a brief background?
I'll be happy to, Rahul. Lipid emulsion therapy was first recognized by Dr. Guy Weinberg, who's an anesthesiologist in the state of Illinois in Chicago. He was actually looking at, it was kind of a serendipity moment for him. He was looking at patients that had some metabolic defects in their TCA cycle, in their Krebs cycle. And some of these patients had some sensitivity to local anesthetics. And he thought that this was related maybe to lipids somehow. And he thought that maybe he could give this lipid emulsion to precipitate this deficiency, this metabolic deficiency, and precipitate the toxicity from these anesthetics. And to his surprise, he found that instead of exacerbating the toxicity was treated. So that was the anecdotal, the story behind this therapy, that he's actually still working on it, and you can review some of his work and the data that he collects on his website, lipidrescue.org.
What an interesting story that gives a great background as to how lipid emulsion therapy ended up becoming integrated into the toxicology world. Do we know exactly how lipids work? What is the proposed mechanism?
I think there are a couple of theories out there that are usually quoted by toxicologists as well as other specialists when we discuss this therapy. One of the major ones is that being a lipid, emulsion, you can administer it intravenously and create a lipid compartment, imaginary lipid compartment in the intravascular space. And this lipid compartment would attract and extract lipid-soluble toxins away from the organs where they are acting and causing their toxicity. So this is why this therapy is recommended for lipid-soluble poisons or drugs that are causing toxicity. Other theories have been promulgated, including a role in the providing better metabolic substrate to the heart, providing additional benefits to the organs that are, where these toxins are acting. But essentially, I think the primary theory that is recognized is the one with the lipid sink.
Interesting. And so, just to summarize for our listeners, the fact that the lipids are going to remain very strongly in the intravascular component and neutralize these toxins, that is kind of how the lipid sink phenomena works. When we think about employing lipids in the clinical realm, where are specific circumstances where we can consider this therapy? And in particular, what would be the dosing range that would be optimal?
So the best evidence for the efficacy of this therapy comes to us from the local anesthetic systemic toxicity, also referred to as LAST. The classic case would be a patient receiving bupivacaine injection for a regional anesthesia with an inadvertent exposure to this anesthetic intravenously. Another scenario would be a scenario with lidocaine, where you will develop this potentially life-threatening toxicity that we are all concerned about when we use these drugs. So that would be one of the major indications for this therapy. And I think intralipids are now essential for an anesthesiologist performing these regional anesthesia procedures. The additional applications of this therapy really increasingly reported in the recent years, primarily with drugs that are lipid soluble. This again brings us back to our lipid sink theory. And if you have a lipid soluble drug, for example, in your case here, amlodipine, then using this therapy when the patient is critically ill and has not responded to your standard advanced therapies is certainly worthwhile, and certainly many experts would agree to using this medication, which is still not approved for this indication by the Food and Drug Administration in the U.S. However, is used here off-label for compassionate use in these critically ill patients.
Very interesting. And so for clinicians, it will be very important to look for in the history any element of local anesthetic use, especially when the differential is going to be very broad with the initial patient presentation.
And luckily for us, these cases are usually known. So the couple of cases that I've had an opportunity to be involved with, and I've actually reported recently on a lidocaine toxicity, was a procedure so I knew this was being used. The first case, the one I reported, was a tumescent liposuction procedure using high doses of lidocaine administered in the subcutaneous space for the liposuction. The other case I had was an injection of bupivacaine for a dental block. So those are two examples of cases where we knew. Now, in more commonly for a medical toxicologist or for an intensive care specialist like yourself, if you are working in the ICU, for example, and you have an overdose, here you are basically going to rely on published case reports, your understanding of the drug that is ingested, if it's lipid soluble or not. And clinically, the patient, is critically ill and they have not responded to your therapies, and you're about to make a decision, what to do. Preferably, you want to give this before cardiac arrest starts. But, years ago, when we started hearing about this therapy, the dogma was to reserve this to a cardiac arrest patient, and then it moved to pericardiac arrest. And I think now it's probably moved even a bit away from pericardiac arrest and to a stage where you've failed to have a difference with your standard therapies. Of course, these standard therapies are advanced therapies. For example, in the amlodipine case, I imagine this child had received high-dose insulin therapy, which is kind of a standard of care now for these calcium channel blocker overdoses that are developing cardiogenic shock. So in addition to calcium, or in addition to vasopressors, often maxed out doses of vasopressors, and then you wonder, what else can I do? And then you have to make that decision.
Got it. And so this lipid therapy, just like you're saying, is sometimes going to be a last resort, especially if the patient is not responding. Dr. Kamat, I know in the ICU we use a lot of Propofol, and Propofol is a milky substance and does have some lipid component. Could Propofol ever be a substitute for lipid emulsion?
No, I think Dr. Kazi can add to this. I think the lipid content of propofol is not enough to act like a lipid sink. Additionally, in a kid who is about to be in the state of pericardiac arrest, I'm not sure that propofol, which itself is a negative inotrope, would be the best drug to use. But I will defer it to Dr. Kazi for his expert comments about propofol as a lipid sink.
I agree with your assessment, Dr. Kamat. I think the idea is that it's not a very difficult drug to get. If you have propofol, well, not propofol really. If you have the some of the lipids that you use for TPN, for total parenteral nutrition, that means your pharmacy is potentially going to have this lipid emulsion therapy as well available. And in the past, it used to be located in the pharmacy. Now, some emergency departments actually stock it in the emergency, locally in the emergency department-based pharmacy.
So now we have decided in our patient to use lipid therapy. What are some of the things that we should watch out for, as well as complications of intralipid therapy, which you would like to highlight?
So I think the first lesson that I've learned is to know where to find the appropriate guideline for the dosing of this therapy, because it's not frequently used. I don't expect people to remember the dose. So looking it up, either through your poison center, for example, our poison center has that guideline readily available. Lipidrescue.org also has that dosing, but essentially it's a bolus followed by an infusion. The bolus can be repeated if you need to, if there's no visible, result. And the lesson that I've learned with lipid emulsion therapy is that the infusion, you should think about limiting the duration of the infusion, because it can cause some fluid overload if you keep it going. So now, and actually, I believe that lipidrescue.org has I don't know when they did that, but I do see now on their website that they are limiting the duration. You want to limit it maybe up to 30 minutes, because I have seen patients. I have seen a patient that was an amlodipine overdose that required that I decided to give lipid emulsion therapy, did not have a drastic improvement as I hoped, and then developed fluid overload with acute respiratory distress syndrome requiring dialysis, or CRRT, continuous venous hemofiltration. And in that case, at the time when I used this drug several years ago, the CVVH procedure was not easy to do, because the circuit was alarming because of clogging in the system, which was not real. The lipid is going to cause the blood to be lipemic, and that can be misinterpreted by the alarms in the machine as something in the circuit. So thinking ahead of the results of your therapy, hopefully there'll be a drastic improvement, but if there isn't, you may have to deal with some of the consequences of administering this therapy. Another consequence, which I have not really seen major issues with, is interference with diagnostic laboratory tests that could be affected by the lipemic blood. There's the theoretical risk of lipid emboli, or some sort of pancreatitis from the high level of lipids in the vascular space, pancreatitis. Those I have not seen personally. I've only used lipid emulsion therapy directly myself about maybe 3 or 4 times in the last decade or so. Certainly, I have not seen them, except what I just told you, the fluid overload. However, they are reported in the literature, and you can find them if you do a literature search. It's also listed in various references.
Absolutely. So the summary is to really focus on the systemic toxicities of lipid therapy, and in these already clinically tenuous patients, watching out for fluid overload. Dr. Kazzi, are there any final pointers or clinical pearls you would like to highlight for our listeners today regarding lipid therapy?
I think there are several pearls that I would like to just leave you with. One of them is that antidotes are very exciting and very interesting because they have amazing mechanisms of action, and they can potentially change the clinical course, at critical moments. However, remember that supportive care, intensive supportive care, good intensive supportive care, often is more important. And using antidotes properly is a very important skill, but also not using antidotes inappropriately is another more important skill. The other pearl I want to leave you with is, remember that there are usually publications related to therapies that work. So cases that had a good response, are going to be published. Those that did not will not be published. So that, I think we call that publication bias. And we have to be aware of that. Now, there's, for the intralipids, for the lipid emulsion therapy, there are good animal studies that support its efficacy. There are some case series. Again, you have to be careful when you interpret these. And often these patients are quite sick, and they've already received what we call, in lay terms, the kitchen sink. So discerning the benefit of one therapy is always challenging. This is why the American College of Medical Toxicology, that I belong to, has published a position statement regarding the interim guidance for the use of lipid resuscitation therapy. And although we discuss the benefits of this therapy that are potentially applicable, we do say that this is not considered yet as a standard of care. And we recommend that these therapies be administered usually in consultation with a medical toxicologist, and again, relying on the appropriate dosing regimen and precautions that we discussed briefly today during our podcast.
We really appreciate you highlighting those clinical pearls. Although we consider lipid therapy and local anesthetic toxicity, in our case, the amlodipine toxicity, it is a multidisciplinary approach. And I think the overall summary is that lipids may not be the true set answer, considering that really important intensive care is going to be important, as well as there's still a lot that we still have to learn about when it comes to lipid therapy. Dr. Kamat, did you want to add anything for our listeners today?
No, I think we are grateful to have Dr. Ziad as the expert who has kind of shed some light on this lipid emulsion therapy. And we thank him for his time today.
Thank you for having me.